So I'm really excited to have the chance to discuss and present this work. It's a big paper, so I'll do my best to get it explained clearly in 30 minutes. It's by Ginger Jin, who's here and help bail me out if I get you hopelessly confused, and her co-authors, and I'm Layla Agha. So broad backdrop, why should we care about this project and topic? This is a project about how we can realize the gains from new innovations and what sort of policies might help us do that. We know new innovations have fueled massive gains in life expectancy and rising costs of healthcare. And so public insurers need to balance the competing aims of how do we capture the benefits of these two technologies and ensure broad access to them while containing the costs of in terms of healthcare spending. And they're thinking about this within a context and a model where there's competition between hospitals to attract patients, and new technology might be one way in which hospitals can attract patients. And insurance coverage will affect the strategic investments that hospitals make in new technology. And then I think this is a structural IO kind of paper where they're going to estimate a demand and supply model. And I think the big payoff from it, from my perspective, is that it lets us answer questions about how to optimize public payment for new technology to balance access and costs in a case where we don't have like a whole series of policy experiments in order to like analyze the payoffs. And so we're going to use the structure of the model to try to ask, how we could improve the payment system. And the counterfactual I was most excited about is the one that thinks about like, is it worthwhile to limit choice? Like when there's many competing technologies in a market, is it worthwhile to limit choice if that would help reduce prices? How do we think about the welfare consequences of that? But they run a bunch of other counterfactuals too, which I'll try to talk about. So the context for this paper is to think about stenting. My stents prop open clogged arteries of the heart to allow blood flow. They can be used both to treat chronic, like coronary artery disease, and in urgent cases when a patient's having a heart attack, you can use a stent to reopen and establish blood flow. There's two main types of stents, and this is really important for the paper. There's bare metal stents, that's an incumbent technology that has been around for decades. And then there's drug-eluting stents, which are the newer technology. They get first approved in 2002. This paper starts a little bit after that. So both of these types of stents are on the market. Drug-eluting stents are coated in a medication that helps prevent the restenosis or the narrowing of the artery after the stent is placed, kind of the blockage occurring again. And there have been numerous generations of incremental improvements in drug-eluting stent design. We've seen changes in the improvements of the design itself, the device, the polymer coating around it, the drugs that it's eluting. And so this is a paper that looks at those subsequent incremental improvements in the desk design and looks at how people choose them and how they affect welfare. They're looking at the stenting market in Taiwan, where public insurance uses what I'll call a reference pricing scheme. And if you hate that language, you should blame me and not the authors of the paper because they don't use this word. But the basic idea is a stent procedure gets paid for at the cost of the bare metal stent. And if a patient wants a drug-eluting stent, their patient is responsible for the incremental additional top-up cost of the drug-eluting stent over and above the bare metal stent. And that's a lot of money in this context. That incremental cost to get a drug-eluting stent, it varies, but it's about $2,000 US, which is a little over like 1 month of income for this on average for this population. So it's a pretty substantial cost. If you want to get a drug-eluting stent, you're going to be paying a lot of money out of pocket, even though there's a public insurance program that's subsidizing the base cost. There's 20 different hospitals in Taipei where you can get a stent placed. All of them offer both bare metal stents and drug-eluting stents, although they differ in their exact portfolio of which drug-eluting stents they offer and at exactly which prices. And so, yeah, this is big part of the model is on like hospitals' portfolio choice of like which stents to choose and how to price them. Okay, so the paper estimates a structural model. These are the basic components of the structural model. The drug-eluting stent manufacturers are upstream and exogenous for these hospitals. This is not a paper about how reimbursement policy affects innovation. I think that's appropriate for this context. The stent market in Taiwan is a relatively small piece of the overall global stent market. So we might not think that changing incentives to adopt a new technology in this context is going to affect innovation. But just so you know, like that channel is just, shut down. That's not the purpose of stent. Innovation is exogenous in this market. Periodically, these companies reduce newer, better stents, and then hospitals have to choose whether to adopt a stent, that means they took a new brand. Or upgrade a stent, that means within a brand I already contracted with, I'm getting the latest version. Hospitals, this is a lot of action in the model is at the hospital level. They're the suppliers that we're really thinking about here. They compete in an oligopolistic manner. They can update their portfolio of stents, as I mentioned, and they can choose how to price the stents. And then particularly the drug-eluting stents, because the bare metal stents no one pays out of pocket for, and they're all priced uniformly. And patients are the final consumers. They choose among hospital brand combinations for treatment. And so the authors build a structural model to fit hospitals' decisions given patients' demand, and it works backwards. Like first you estimate the demand equation for the patients to see how they choose among hospitals' brand pairs. And then you model the hospital decision-making. They choose how to price their stents. And then once we understand the pricing process, we think about the choice of portfolio of stents to offer. And then once we have estimated all of those stages of the model, then you can simulate counterfactual changes in payment policy. Okay. And the big payoff, as I said, is the counterfactuals. I'm gonna skip ahead here. Okay. The data that they use from this, they have claims data from Taiwan. What tell them for each individual patient who got a stent, the sample is restricted to people who get stents, which stent did they get at which hospital, when. They have the prices that the patient would have to pay for the stent. They hand collect, it seems like a price data series at the hospital by stent product by quarter level. And they have patient demographics. In particular, they have a comorbidity index for patients that they use, and they match each patient to their zip code and then get the average income in the zip code as a proxy for the patient's income so that they can have, for example, price sensitivity varying by this income proxy. And they focus on Taipei as one single market with 20 hospitals. Okay, so a few background facts before we dig in deeper into the structural work. These are plots of the 5 major stent manufacturers in this market. And this is showing over time the take up of different generations of that manufacturer's stents. And what you can see is all the manufacturers are kind of successively releasing different stent products. These are drug-eluting stents over this period. Another thing that I thought was pretty striking here is that the old stents really disappear fairly quickly, in my view, from the market, and the new stent takes up. So there's not a lot of overlap within manufacturer, where for many quarters, there persistently seem to be really offering multiple stent products. And that's an interesting strategic choice that's exogenous in this setting, but you might think a manufacturer has a choice between, I could offer 2 products, like the older, cheaper one and the newer, better one, or I could think that then I'm kind of competing with myself, and I could put the old one on the shelf and stop making it and make everyone buy the new one. And it seems to me like the latter is kind of what's going on because of the so fast kind of de-adoption and switching that we see in these pictures. But and then this is a picture looking at pricing of the different generations over time. And one sort of thing consistent with that story maybe that we see is that often when a new generation comes, the old generation, the prices that are observed for it go up, which kind of, so like you see here, like the red Gen 1 kind of comes up when Gen 2 is released. We see it here, the red Gen 1 increasing price, but we saw the use falling off really quickly. So I'm not sure like who around is still purchasing these, but I think it's sort of consistent with this idea that manufacturers are really kind of shutting down use of the old one and pushing it. Okay, there's 20 hospitals. The data is kind of organized at the hospital quarter level. So they can see about 100 stent choices in each hospital quarter. Each hospital manages a portfolio with roughly 4 or 5 brand choices. So they are offering kind of a variety of different stents that a patient could choose. They all offer, as I said, bare metal stents where the patient has no out-of-pocket costs, and a portfolio of drug-eluting stent choices that will have different prices attached to them out of pocket. And roughly 40% of patients in this market are opting to pay for the drug-eluting stent. So we see substantial use of both of options. Okay. So now I'm going to go through the structural model, like the approach to estimation. I'm going to give some commentary as we go, and then we'll look at the results of the estimation and the counterfactual analyses. So the demand setup, I think, is a fairly standard demand estimation. where patient utility is modeled as depending on which stent product they get and at which hospital they get it. In particular, and how much they pay for it. In particular, patients care about whether they get a drug-eluting stent, that's DES, versus a bare metal stent. So that enters the utility function directly. They care directly about whether they get the newest generation of stent. They have a disutility of the out-of-pocket costs that they face, so that's very natural. They care about what hospital they go to, so that's a hospital fixed effect. They care about which brand they're getting, so that's the brand fixed effect. And these are random coefficient models where the individual specific coefficients can depend on the patient's comorbidity index and income that might affect their evaluation of whether they get a drug-eluting stent versus a bare metal stent. It might affect their evaluation of getting a new stent versus an older stent model, and it might affect their price sensitivity. Okay. So a big problem in general in IO demand estimation is you want instruments for price. Otherwise, for example, you might understate price elasticities if my utility of getting a particular product is correlated with the price. And so the paper that's whatever a common challenge. The paper uses the following three instrumental variables to try to instrument for price variation. One is exchange rate fluctuations, because these stents manufacturers are based elsewhere. They use the exchange rate between the new Taiwanese dollar and the US dollar to get time variation that would shock like the prices potentially of like all the drug-eluting stents by changing the acquisition cost for the hospitals. The second instrument is the number of other hospitals in the market that are adopting the same brand of stent. And the third is the percent of hospitals in the market that are offering the latest generation of that brand. And then once they have these instruments, they use a control function approach where they regress the drug-eluting stent prices that they observe on these instruments and then control for the residuals in the utility equation, demand equation. So these are my like kind of comments and thoughts, and this is a really hard thing to do. Like it's very, I think, hard to think of what good instruments would be in this context, and then how to deploy them is also not trivial. So my biggest concern was like, are other hospitals' adoption decisions for the same brand really exogenous to consumer sort of valuation of that brand? Because if there's or of that stent model, if there's correlation in how people value that stent model, like across the different hospitals are making the adoption decisions, then this variation might capture that patient's utility from that product. But on the other hand, it's quite hard, I think, to think of like really great instruments in this context. So the authors are really coming up against a very difficult problem and trying to make some headway. I was trying to brainstorm of like whether there were other possible instruments, and I'm not sure that any of these are going to be possible in their context. One would be production. Are there other production cost shifters? Like, can you look at where these stents are manufactured and then get shocks, like depending on, for example, labor markets in those places? What about like characteristics of competing goods as we see new stents enter? Maybe that could be used as a set of instruments. There is also, I think, an interesting change in just the level shift in the reimbursement level for bare metal stents that happens during this period. And the authors have other work exploring that more directly, but I wondered if that generates price variation and how much I have to pay out of pocket for a drug-eluting stent. And that policy variation might be somewhat exogenous to like the quality of the drug-eluting stents on the market. And so maybe that would generate some useful exogenous price variation for the drug-eluting stents that could be useful in estimating demand, but those are just a few ideas. Okay, second, the control function. So we need instruments for sure. They have a set here. It's a hard problem. The second is like, once you have the instruments, like how do you actually implement the estimation? This is not exactly my area of expertise. I got kind of curious reading this paper and started reading up a little bit on like control function approaches and different approaches to instrumenting demand equations. And my takeaway from my beginning reading of this literature is that there's some control function approaches require strong functional form restrictions that can be problematic in simultaneous equation modeling, like demand and supply systems. And so there might be alternative ways of using the IV moment conditions in estimation that help relax that. So that's something to think about. Ginger tells me they are working on adding distance and it doesn't make a big difference to results, so that's wonderful. It wasn't in, distance isn't in the version that's presenting now, but that's coming down the pike. I think modeling acute versus elective demand for acute versus elective stents could be important, because in an acute care setting, when the patient has a heart attack, they might have less scope to really express their preferences through their choices if they're making the decision in a very kind of pressured and time sensitive way. So that's something I don't, maybe they already restrict to elective stents, or if not, that might be something that they could do. And then I was kind of broadly interested in like how much information patients really have about stent options. We're going to be interpreting the results of this demand estimation process as revelations of patients' utility. And so it matters whether patients understand the choices that they're making. Okay, so that's the demand estimate. Now I'm going to talk about supply. So in the supply model, there's two stages. The hospitals choose a portfolio of which stents they're going to adopt and offer. So they could either keep their portfolio the same, they could upgrade, like if I have the Abbott stent already, I could get the latest generation Abbott stent, or they could adopt. So they could say, I don't have any Medtronic stents, but now I want to start stocking Medtronic stents. Once they've chosen their portfolios, the portfolios become public knowledge of all of the hospitals simultaneously choose a portfolio, then they know what their competitors have chosen. And then in stage 2, they set a price for each of the stent models in their portfolio. The model assumptions are that it's a static setup, so they're choosing their portfolio and pricing to maximize payoffs in the current period. They only can make one modification to their portfolio per quarter. And they solve the model backwards, like first solving the pricing problem, and then given the pricing solution to the pricing problem, solving the portfolio optimization. The pricing problem, I think, is written in quite a standard way. So the hospital, this is like thinking about the hospital profit and revenue side. For the fraction of patients that choose a drug-eluting stent, they charge a price for that stent model. That's the out-of-pocket price that the consumer faces. They also get reimbursement from the National Health Insurance Program, but they have to pay an acquisition cost for the stent, like the marginal cost of that stent. And so they get profit that way. And then they also get profit from placing bare metal stents, and that it's assumed that they have a 20% margin on those. So the kind of cost is assumed rather than inverted from this equation for the bare metal stents. Okay, so they take first order conditions of the pricing problem to solve for the optimal price. They invert the pricing equation to estimate the marginal cost at the hospital by stent by quarter level. So for every stent that the hospital has, they can, based on the price, infer what the cost would be that would make that the optimal price. For stents that they don't see in the hospital's portfolio, they don't know like what price the hospital would have charged for that stent. So they impute the cost of that stent by looking at the cost of that stent at other hospitals and adding in like in a model that accounts for like a hospital, a fixed effect and a brand fixed effect, so that if this hospital tends to get a better deal on their stents they have in their portfolio, you assume they'd also get a better deal on the stent they don't have in their portfolio. Okay. And then once you solve this pricing problem and you know the costs of each of the stents, the acquisition costs for each hospital and stent pair, then they can solve the portfolio problem and say, which stents do I want to adopt? They model that adoption is costly, like adopting a new brand of stent is costly, and updating to a new model of stent within a brand that you already contracted with, that's also costly. And that the costs are going to depend on kind of how much experience you have, how many new generations you have, your experience with that brand, how popular that stent is in the local market. So then they can solve for the optimal portfolio choice. I think my biggest kind of question or discussion point or thing about this supply side modeling are two. One is what we've shut down the channel, I think here, that there's volume discounting in the hospital contracting, that at least for when we think about what the cost the hospital would have to pay if they added a new stent to their portfolio, that's imputed from like the cost that other hospitals pay, but you might imagine a hospital could negotiate a better deal with a particular manufacturer if they did some sort of exclusive contracting arrangement, or that there might be some volume discounting in this market. And that channel, I think, is partially shut down through the cost imputation. It's probably a somewhat hard problem to solve, but the costs are the cost of like the marginal cost of an additional stent is not endogenized in that way, I think. The second thought that I had is that this sort of models that, like, for example, an updating to the latest brand is a choice that a hospital could make or could choose not to make. But it seemed like from the descriptive statistics that the brands were really like ending the sale of the older models pretty quickly after release of the new models. So hospitals might be forced in a sense to, I wondered, to make an updating cost. Maybe that's already kind of in the background because maybe the cost of obtaining the stent kind of is increasing, you know, in this model, and that's kind of capturing that. But I worried a little bit that we might underestimate updating costs if we think all the updating choices are voluntary, when really the updating choices are being sort of forced by the manufacturers that stop selling the old version. So those are two kind of small things, but overall, I think this is a very thorough model, and it's really like a heroic effort to bring together all the complicated piece of this market into something that's tractable that they can estimate. I have 5 minutes, right?
8 minutes.
Okay, sorry, I'm talking really fast. I apologize. It's a really complicated paper with a lot of cool stuff going on. But now we're at results. So, okay. So I'm going to talk you through briefly the demand estimation results and the supply, and then we're going to go to counterfactual analysis, which is the really big payoff from all of this structure. Okay. So for demand estimation, we look at the set of choices that patients make as a function of the prices they face for those choices, the characteristics of the stents, and like whether it's drug-eluting or not, and whether it's the newest generation or not. There's more interaction terms in this demand system. Brandy told me last night that my biggest job as a discussant is to make the table short enough to be digestible. And so if you're still staring at this and saying there's too many numbers, I promise you I cut it down from a table and approximately twice as many numbers. That's what I'm trying here. Okay, so they find very large sensitivity to price. Okay, so I was a little bit worried about the instrumenting price, and I thought the bias might go in the direction of understating patient sensitivity to price. That said, what they find is a very high elasticity of demand of around 5, right? So it's a patients are quite elastic to, demand is quite elastic to the price of these stents. That might make sense that these are really expensive products relative to income, and so maybe that's why we see such high price elasticity. We do see that wealthier patients are a little less price elastic, which I think is quite natural. We also see that sicker patients who have higher comorbidity indices are less price elastic. I think I would have guessed I went in the opposite direction, but I don't know, maybe like something, but maybe they're facing other medical expenses and strained. Patients prefer drug-eluting stents, and patients prefer having the newest generation of stent. There's also substantial heterogeneity in the random coefficient models. The standard deviations on the elasticities are quite large. And so there's high price sensitivity, strong preferences to get the latest stuff, but also a lot of heterogeneity in people's preferences over those things. So those are the like kind of key components of the demand estimate. And then they look at adoption and costs and upgrade costs. And they do find that it's cheaper to it. They find that like adoption costs and upgrade costs, you know, do depend on these like factors they had that were trying to predict these costs. And then they take this, so this is kind of the output of the supply side information for the portfolio updating problem. Okay, so the model fits quite well. They look at the kind of actual decisions to adopt a new stent or to upgrade your portfolio, and they compare it to like what the model says the optimal decision would be, and they find quite close fit. They look at what the model implies about the marginal cost, so they don't observe, again, they don't observe the cost that hospitals pay for each stent that they acquire or place. So they have to impute that from the inversion of the pricing equation. The imputed marginal costs here are plotted. There's dispersion across brands. One thing I thought was interesting and notable is there's this period where for all brands, there's this pretty steep decline in the costs of acquisition. And this coincides with the decline in the reimbursement rate set for the bare metal stents. And so I thought this was very interesting. And I had two thoughts about it, and I don't know which is correct. One is maybe if all of a sudden everybody is facing much higher out-of-pocket costs for a given price of stent, the manufacturers will say, I want to keep selling drug-eluting stents to this market. All of a sudden, everyone is facing much higher out-of-pocket costs for it. Maybe I need to cut the price that I'm selling my device to the hospitals if I want anyone to keep buying it. So maybe the costs really do go down. The other possibility is like maybe the costs don't really change that much for the drug-eluting stents when the reimbursement level for bare metal stents gets cut by a lot. And maybe this is telling us something about the estimation process, and I don't know which of those is true, but if there's any way to get some more context or talk to people around that time about whether there was big fluctuations in the acquisition costs for drug-eluting stents, because these are really major changes that are coinciding with the policy, but I don't know how to interpret them. Okay. So now in the last 5 minutes, you stayed with me, hopefully more or less, through a lot of machinery. We had this whole, model of the market interactions. And the reason to go through all of that is so that we can do these counterfactual analyses. That's the major payoff. And these are counterfactual analyses that are out of sample. We don't have variation in how much hospitals there are in this market, but we could use this model to understand what's the role of competition in access to drug-eluting stents, in the prices that people pay for them, in consumer welfare and government spending. We can think about what would happen if patients had stronger preferences for getting the newest stuff. And we could think, and this is a set of counterfactuals that I was most excited about, different ways of designing the government subsidy and how that would affect costs and access. So that's the final section of the paper, and I think where the benefits of going through all of this really come through. So I'm going to try to spend most of the time on the government payment, but to quickly say, they start with a counterfactual that changes the number of hospitals in the market. It starts with 20 hospitals in the market, so that's a fairly competitive market. So these counterfactuals are about reducing, from what we see, reducing the number of hospitals in the market. And if you were to reduce the number of hospitals in the market from 20 towards 2, I think they have intermediate points as well, but kind of things just keep moving in the same direction. As you might expect, if you reduce competition, you reduce consumer surplus, prices go up, patients have to pay more out of pocket, hospitals increase their profits, the ones that are remaining in the market. There's actually little change in the use of drug-eluting stents, and you see some more adoption of the newest stent options, although there's less product variety overall available. So I thought that was quite intuitive, kind of what I might have thought would happen if you reduce competition, although I didn't have very sharp predictions on what would happen to drug-eluting stent use specifically. Okay. The second counterfactual that they go through in the paper is what happens if patients have even stronger preferences for having the newest demand? So actually changing a parameter of the patient's utility function to give them stronger desire for newness. And this, I think, also, once you make that tweak to utility function, I found the results that kind of come out of that exercise relatively intuitive. Hospitals can make more money now selling new stuff to people. So it increases hospital profits. Patients are more likely to get drug-eluting stents because they want the new stuff, and there's more adoption and more use of the newest. Okay, this one I had a little more trouble thinking about because I don't know how many levers the policymakers have for changing people's preferences over new stuff, but I guess you could think about advertising campaigns or other types of information campaigns. The ones I was most excited about were when we start to get into how we reimburse for stents. So one is you could think about ending all coverage for drug-eluting stents, the current, which is this reference pricing system, or you could think about increasing the generosity so that you'd actually pay more for a drug-eluting stent than you do for a bare metal stent. and they simulate what would happen under those different counterfactuals in more or less competitive markets. I'm going to focus on what happens in competitive markets, although the patterns are pretty similar. But what happens is consumer surplus increases because patients like getting, if you increase the generosity of payment for drug-eluting stents, patients get more new stents at less costs. Okay. Hospitals make money selling these drug-eluting stents. Government spending goes up a lot because you're making payment more generous, but people are getting new stuff. You can try income targeting the payments for drug-eluting stents towards low-income patients. They simulate outcomes there. I think I'm like running out of time. My one puzzle about this is they try making a coupon available only to the poorest. So there's nobody gets paid any payment for drug-eluting stents. This is only poor people get paid for drug-eluting stents. This is only rich people get government coverage of drug-eluting stents, and this is both poor and rich people get coverage of drug-eluting stents. So there's 4 scenarios here. And what surprised me the most is that consumer surplus is a little lower when both poor and rich people get reimbursement for drug-eluting stents than when only rich people get it. And I would think that like giving more people subsidies for stents would like increase surplus. And so that I didn't have an intuition for that. It puzzled me. The other elements of that made sense. Okay, the last counterfactual I want to tell you about, I'm going to give Ginger the floor, is selective contracting. So what if the government could restrict choice by contracting with only 2 drug-eluting stent manufacturers, but by doing so could negotiate lower acquisition costs for the hospitals. So I think this is really interesting, like potential here, because through the selective contracting, we get a bulk discount, but there's a cost because there's less variety potentially available. And this is maybe where I thought this model really shined, because we know at least if we take the demand revelation seriously, what people's preferences for variety are, what the returns are to having a big portfolio of stenting options on the market. But we find that despite people's different preferences for different stenting options, that reducing the number of options increases surplus if it comes with this, if you can get that reduction in acquisition costs along with it. They assume there's a 20% reduction in acquisition costs as you restrict the number of options on the market. So you can then, this is where like the kind of free lunch comes in or something, like it's good for everybody, like hospital profits don't change that much, consumer surplus increases and government spending doesn't increase that much. It assumes that you can get this bulk discount, but if this kind of bulk discount works, it might be worth closing off options in the marketplace in order to get these better prices. Okay, so I know I'm like out of time, so I'll give Ginger the floor. But this is a super cool paper. I'm really glad I got the chance to dig in. The structural modeling lets them do a whole bunch of counterfactuals that I otherwise wouldn't have a toolkit to offer in the absence of specific policy experiments. And so I learned a lot from reading it. Thank you.
Thank you so much for the clear presentation, constructive comments. The paper just uploaded on SSRN a few weeks ago, so it's quite preliminary. I really appreciate your tolerance of the immaturity of the paper and still managed to present it in a super clear way. I also want to thank the conference organizer for including this preliminary paper in the program. This is my first time attending AQ conference. I was expecting like a straightforward healthcare conference, but it turns out that it's much more diverse. I see reduced form methodology, structural methodology. I also see education, healthcare, public finance, and hopefully you like the IO aspect of this paper. So it's kind of remind me of the graduate school, but on the frontier of the research. So I really appreciate that. Given that I'm the last presenter, I would like to propose a round of applause just for the organizers. And back to Lina's question, I want to sort of give you some motivation of why we're doing this. We have seen a lot of public policies in healthcare industry, but my impression, especially from the IO economist perspective, is a lot of strategic players going to respond to that policy, and we have to take into account that strategic interaction before we conclude whether that policy is going to be welfare enhancing or welfare reducing. So that's why in this paper, we really want to kind of shine a spotlight on how hospitals going to react to this, and especially in like their decision in whether to adopt a innovative medical device will be crucial for access as well as the cost for both the insurer and patients. So that's why we're working on this. Just to give you some background, I think Nina does not mention this too much. You should be aware that not everybody is suitable to have a drug-eluting stent. Okay, although it's supposed to be higher quality, roughly speaking. However, it does carry the risk of thrombus, which means some blood clot in the vessel, which could be emergency situation. However, the advantage of having the drug-eluting stent is going to reduce the risk of the vessel become renal. Okay, and because of this, the sicker patient, especially those who have other implications, actually advised not to use drug-eluting stent. So in our data, it's very clear that relatively healthier, younger patients ends up using the drug-eluting stent, while the sicker with other comorbidity situations ends up not using. So that's a very important control for the Charles index and their sensitivity to using the DES. I also want to emphasize that the products were all manufactured outside of Taiwan. Okay, so Taiwan is kind of like enjoying the innovation from the rest of the world. However, the overall availability of those new products tends to be about 2 to 3 years later than the US FDA approval. Okay, so I think some of the supply shock that we probably should use more of is kind of the arrival of that model available to Taiwan, because they need to get the Taiwan's FDA approval before marketing, and that's typically it's lags some years behind the US ones. Okay, maybe we should use more of that. And let me see the questions on demand. Let's see. Okay, maybe this is where that we could enhance the IV. That's instead of using the number of models adopted by other hospital, we could just be using this when it's the first time that's the manufacturer offers certain models to the Taiwan market. I know there are many more people in this room probably have better idea about the control function literature. I would love to learn more about that, and definitely we can do more sensitivity check on functional form and maybe using the GMM rather than the control model. And as Nina has mentioned, that's we now have the distance data, and on average, this is kind of one metropolitan area is relatively closely knit. The median distance is about 8 kilometers, so that's like less than 10 miles. Actually, 75 percentile is about 10 miles. Okay, so the choice that it's relatively close, but we still find the distance matters. It does not affect other coefficient though. So hopefully all the counterfactuals do not change much. Okay, and this is a fair question. That's to what extent patients really know all the options. I mean, my hunch is probably same as Elena's. That's probably it's impossible for the patient to know all the like 20 hospital times 5 models in each hospital. It's subject to how the hospital and doctors present those choices in front of the patients and family. So maybe you should think about that decision black box is kind of a joint decision between doctors and patients. Okay, let me see. Other, and on the there was a pretty substantial, about 20% declining in the reimbursement rate in 2009, but that reimbursement rate reduction is for both the BMS and for the DES. Okay, so it's like a overall industry shock to this, not just on the DES alone. So in that sense, it's sort of harder to distinguish that from the time trend itself. In the other paper, when we look at like hospitals rely more on this as an income versus hospital rely less on this, we don't find much impact on the DES price after reimbursement, especially after we control for the model changes. Okay, so seems like the margin of response, if any, is probably on the model adoption rather than on the price and itself, in particular to that shock. Okay, and let me see. as far as I know, the current paper is including all the inpatients records, so we probably should do a robust check, excluding the emergency room admissions. I expect them to be a minority of all of this. Okay, and we also tried this patient choose sequentially, say hospital first and then model, but the empirical results actually reject that structure. So that's why we adopt a random coefficient, try to give more flexibility in the potential substitution patterns. On the supply side, I agree that we do not have a very clear micro foundation on the marginal cost. And so you can see that we infer the marginal cost from the first order condition of the pricing decision, right? So we're able to kind of infer the marginal cost at a very granular level, hospital, brand, model, and the quarter. So in that sense, it sort of doesn't matter what drives those marginal costs. It could be driven by volume discount negotiation. It could be driven by something else, right? The long-term relationship between the salesman and the hospital and so forth. Whatever the micro foundation driving that, that's sort of like it's estimated into that way. So if a hospital was very strong bargainer, was able to get a lower marginal cost, then we'll see that in the marginal cost estimation, which pass through towards a lower price facing consumers. Okay, so in that sense, I don't think that's lack of bargaining model would really hurt us. It just may be an interpretation of exactly how we think about the marginal cost. And back to your question about to what extent the insurer is able to get a lower marginal cost. I think it really depends on the volume, right? That's if as a central negotiator with a manufacturer, instead of one of the 20 hospitals negotiating, they could have shifted the volume much more, and the selected brands would have incentive to welcome that volume by giving a deeper discount. So I do think there's a room for kind of centralized negotiation to reduce the acquisition cost. I think one lesson we have learned from the counterfactual is that, well, if the insurer sort of thinking hospitals like the enemies, I'm going to reduce the reimbursement rate so that you will just do your business, but I want to save costs. If that's the magnitude, then it's going to reduce the incentive for the hospitals to adopt innovation, which will backfire because patients will not have much choices, right? Well, the selective contract is better than that because to some extent, the insurer is helping the hospitals to lower their costs so that they could still have a relatively healthier profit margin so that they still have incentive to upgrade and adopt new brands. So I feel like it's a tricky balance here, but sort of the reason that we see this win-win-win situation in the selective contract was because the insurer, to some extent, is helping rather than kind of just treating the hospitals as the enemies. I guess my last point is maybe you raise a question about the patient coupon say. Let me see. Okay. It's a little tricky here. Right now in the data, the price is about 60K, okay? But if there's no reimbursement at all, the hospitals have to pass through sort of the lack of reimbursement to patients. So that's why it raised to about 80, okay? And if only the poor patients got the coupon, then they do not reduce this much, even if they could get extra money from, because they want to cater to this type of patients, okay? And here, that's like here, why they're still doing similar thing, and that's because the model required them to have a uniform price charging to every patients. And while the poorer patient has more price sensitivity than the richer patient, but richer patient would have less money from the NHI. So if you sort of take into account kind of differential price, but you have differential price sensitivity, but the hospitals have to charge uniform price. In this case, they end up charging a little higher than this one. That's why the patients, to some extent, is a little worse off because now they're facing a higher price. So overall, in the patient coupon counterfactual, we actually don't see much gain. It's more like a redistributional effect, unlike the selective contract that could have a kind of, you have a breathing room so that all the parties could be better off. But of course, I guess the potential harm is what about the non-selected brands, right? That's, they may be shut out of the market, and then we may hurt the long run yellow patients. Yeah.
Thank you.
Open to any questions. Thank you.
I had a conversation with University of Tennessee's Medical Center CEO a couple years ago when we were talking about total knee replacements. And I asked him about, what really determines what knee goes into what patient, how much of it is heterogeneous patient need versus physician preference. And his answer in that context was it was more like 80% physician preference and less about patient need. What's your read on what determines the choice in this context? Is this mostly about heterogeneous patient need, or is this mostly about, physician preference for a particular type of stent?
Probably those. I think we see a very common rule of thumb. For example, the sicker patients are less likely to use the DES. That's across the board. But we actually have doctor ID. We also see some heterogeneity in doctor's choice of which stent to use. So I would say those. Yeah. And then we heard anecdotes. We heard is like patients basically follow whatever the doctor recommends.
So I maybe I missed it, but for the people that can have both, how good is having the drug one versus the, like, do you have data on success rates? Like,
Yeah, that's a good question. We actually look at admission outcome like 1 month, 3 months, 6 months readmission rate or mortality rate. We actually don't see a big impact in those outcomes by using the DES. However, that being said, you may argue that's the benefits of DES is more in the long run because it's a reduced risk of a gradual re-narrowing of the vessel.
okay. And then in suggesting IVs, can you play a little bit around with the timing of the future generation arrival? Like you know from your data when that new device is gonna hit, right? But you as a consumer, X years late before,
Right.
you don't know it. And maybe they start pushing, maybe they start saying like a year before, some month before, like, you wait a little bit, that maybe the next one is gonna come in a couple of months, and then you see that drop, right, from the current one. So that from the patient point of view, that timing is exogenous, and maybe you can play a little bit with that.
We can try it, but I doubt that patients and doctors will be that forward-looking, actually. We actually don't think the hospitals are anticipating the future generation, but
That's fair, yeah.
Yeah, I'm interested in the price elasticity. Do you have a sense of if the second choice is a different DES, a BMS, or leaving the hospital?
I think the second choice is BMS, because BMS is zero price for patients. And I think in the short run is actually very similar effect. It's just in the long run, whether like how quickly you will have the vessel re-narrow. And by the way, if you take the DES, you actually need to take medication like aspirin to sort of reduce the risk of clotting. So it's again, it's not like a vertical, absolutely better for everyone.
Yes, so what countries make the stents?
I think 3 are US, 1 in Singapore.
One in Singapore.
And there's 1 in Japan, but that Japan one was withdrawn somewhere in the middle of our data.
So the instruments you're using are the exchange rate with the US and with Singapore?
No, we just use it with the US. The Taiwanese dollar was US dollar, the
So-
exchange rate.
So wouldn't the Singapore help?
We could try. I mean, macro people probably would know like how closely correlated the exchange rate is. Yeah, we can try that.
One more question.
Yeah, just related to that, I was wondering whether the exchange rate goes into the pricing decision of the hospital, because I would think in terms of deciding when to order, how much to order, there's exchange rate considerations would be large in that.
I think my guess is mostly coming into the inventory of the manufacturer. Like to what extent the hospital would buy a bulk from the manufacturer is actually an open question, because I heard that sometimes the hospital may not have an inventory there. They actually have the manufacturer salesman in the surgery room, just ready to sell any number of stents that the patients would like. So in that sense, the inventory risk is actually off the hospital, but more on the manufacturer side.
All right, let's thank the